look at your group. I'll try to log in with two devices and it's bringing issues. So I'll just try to keep alternating. So I'll just ask someone random. Maybe start with Sydney. But she said she's in the library. Let's start with Kwamboka. There's Kwamboka here. Kwamboka, are you with us?
Yes.
Okay, so what do you think a wound is before I start discussing it? Kwamboka? Hello? Maybe we can have someone else. James?
So I think a wound is a disruption in the.
Sorry?
Can you hear me?
Yes.
I think a wound is a disruption in the maybe the epithelium.
Mm-hmm. All right. That's one concept. What does Abdallah Mohammed think?
I think it's a type of injury
Uh-huh.
in which a skin it can either be torn or cut or punctured.
In which what can be done what? Sorry?
Um,
What did you say?
I meant
Yeah.
it's a type of injury
Yes.
in which skin can be torn, cut, or punctured.
Okay.
If it's an open wound, yeah. Or it could be a blunt force trauma that can cause a contusion, maybe.
Okay. So what I want you to get basically is that a wound is a disruption in the normal architecture of cells. So I think for plastic surgery, our main focus is usually cutaneous wounds, but there are more wounds. There could be wounds. There could be wounds, as Abdullah is trying to say, that you could have a cut in the intestines, you could have a cut on the liver, but most of the time when you get a wound question in your exam, they'll be most of the time talking about the epithelium, okay, which is what James was talking about. So that's what I've written there. A wound is defined as damage to biological tissue integrity, including skin, mucous membrane, and organ tissues. So what both James and Abdallah were saying are true. So you just combine it in that, and that's basically what it is. So at least we are all on the same page in what we're talking about. So how do we classify wounds? Dixon, Mwangi, what do you think about classification of wounds?
Okay. When you classify wounds, I think we can classify it as either open or closed.
Yeah.
Yeah. I think that's the classification.
So what do you mean by open and what do you mean by closed?
An open wound most of the time would appear when you're having maybe a sharp or penetrative penetrative mechanism of injury, whereas a closed wound would be more of a blunt force trauma.
Okay, so anyone else with another idea? Hillary? Kiplangat.
Okay, so you can also have either a clean wound, either clean contaminated or dirty.
I think most of the time, when you're asked about, because there are many ways you can classify wounds. So what Hillary is bringing to the table is what I think majority of your lecturers will try and ask you. Actually, my main goal is to make it easier for you to pass exams. So that classification is what most of the time they'll tend to ask. So Hillary, do you mind telling us more? What is a clean wound? What is a clean contaminated wound? What is a contaminated wound? What is a dirty wound? Hillary?
People try on clean wounds.
Yeah.
So I think when you have a clean wound, it means it's made under sterile condition, where the organisms are present and the skin is likely to heal without any complication. While contaminated wounds, maybe they arise from accidental injuries and will have pathogenic mechanism and maybe presence of foreign bodies in the wound.
Okay.
Not so sure about the others.
Okay. Maybe you can have Felix Majani. Felix, is there an opinion you have?
Yeah. So for clean wounds,
yes,
these are wounds that are uninfected. They don't have any inflammation, and they are sterile.
Yeah.
For clean contaminated, they have no inflammation also.
Yeah.
But here, and there's let's say there's penetration of the hollow viscous, but it's still sterile.
Okay.
Yeah, these are like hernia repairs. Yeah, then contaminated, here you have inflammation, but is non-purulent. And you have now full penetration of the hollow viscous. An example is like colon surgery.
Okay.
Yeah, and the dirty ones, you have purulent, and the contaminated one is less than 4 hours. Now in the dirty ones, it's more than 4 hours, it's purulent, you have inflammation. Yeah, and it's non-sterile. Here is like dog bites, a burst appendicitis.
Okay.
Yeah.
Yeah, I think that was a good attempt. Just to make it clearer, class 1, which is clean wounds, you're not entering any hollow organ, and by hollow organ I mean respiratory, GIT, GUT. You're not entering any of those cavities. 2, you're not when you're breaking the whatever barrier that you're breaking, it's aseptic. So that means there's a high chance that you're in theater. Okay. You've gowned up, you've scrubbed, you've covered the patient vizuri, all that stuff, and then there's no inflammation, as you said. So the examples are very clear over there. You have breast surgery, and in breast surgery, we're not talking about an abscess. We're talking about other things like removing a lipoma and stuff like that, where there is no inflammation. The big thing is here is there's no inflammation. The other one is a C-section. Again, you might be wondering, you're saying you're not entering a whole organ, but in a C-section you kind of enter one. But in this case, we're talking about when the membranes have not ruptured. So it's more, usually most of the time it's not an emergency. The membranes are intact, so it's a C-section. I think that one you guys did most of last year. The other one that you think about is an XLAP with no bowel resection. I don't know. Do you guys know what an XLAP is? I don't know. Do you guys know what it is, Felix? Felix, do you know what an XLAP is?
Not really.
Okay, so it's
I could try.
Okay, so James.
Exploratory laparoscopy.
Laparotomy, yes.
Laparotomy, sorry. So usually it's indicated in a burst abdomen, maybe secondary to appendicitis. Yeah. What?
Okay, so yes, so basically in exploratory laparotomy, what you're doing is you're opening up the abdomen and you're checking what's under the skin and seeing what's happening inside. So whichever indication, the indication that he's talked about when there's a burst appendicitis or something like that is more of a dirty wound, because in that case there's abscess, there's pus and all that. But when you do an XLAP without any bowel, again, as I remind you guys, you're not entering any whole organ. So in a situation where maybe there are just adhesions that you're clearing, and you're not touching any bowel, then that's a clean wound. The other one is an eye surgery, hernia repair is very common, and total hip replacement. So you'll find that majority, if not all, non-traumatic orthopedic ones, especially for the older patients, are usually they're clean wounds. Clean contaminated, as he said, in this situation, you're entering those whole organs in a controlled environment. Again, still most of the time you might be doing it in theater. There's no inflammation and there's no spillage from those organs. So I've put for you all those organs, the GIT, GUT, cholecystectomy. So when you're doing a cholecystectomy, one of the reasons you're doing is because it's inflamed. And we're saying here it's acute inflammation. So you could be doing a cholecystectomy when it's a chronic inflammation, yeah? So keep that in mind. When you're talking about clean contaminated, you're saying it's not acute inflammation, okay? Contaminated, in this case now there's inflammation. There's acute, most of the time it's non-purulent, so there's no pus happening, okay? There's visible spillage, there could be necrotic tissue, but there's no evidence of pus in this case, okay? So in this, you can have appendectomy, bowel resection, cholecystectomy. Now it's acute cholecystitis, but it's usually, again, when you say there's a compromised sterile field. So in this case, the sterile techniques are not observed. So you find that now you introduce contamination into your field. So maybe it was a clean surgery, maybe you're just doing a breast surgery, or maybe even a total hip replacement, and then your equipment fell on the ground. So and you still have to continue surgery. So you pick up the equipment. I've seen this happening in public hospitals. They pick up the equipment, pour spirit, and continue. So in that case, the wound has moved from clean to contaminated officially. Okay. So now when you go to the next one, it's dirty. This one has pus. There's dead tissue. There's a lot of weird things happening there. There's fecal contamination. So in this case, usually perforated GI. So that's appendicitis, even the bowel themselves. You could be having intra-abdominal abscesses, infected amputations. So what I want to impress upon you guys is this infection risk. I don't know whether it's very clear on your end, yeah? The infection risk increases there's a chance that they could ask you this in MCQs about the infection risk, but you can always, I think these numbers change over time, so you can always check for yourself. I think this is supposed to be less than 5, but these numbers increase as the class of the wound goes up. Okay, so I hope everyone has understood that, because I want to take most of my time on this slide, particularly because they like asking questions about this. This is where I think majority of the time they'll ask you questions. Sorry?
When you mean no inflammation, what do you mean? Like when clean contaminated, you said there's no inflammation. Like no inflammation where exactly? Like in wound healing, or is the condition, or what?
So now those are stages of wound healing. You need inflammation. What you're saying is by the time you're cutting into that particular wound, because as you said, clean contaminated, there's a higher chance that you're in theater and you're going to cut on these areas. So when you're cutting on these areas, there's no sign of inflammation what you're cutting. You get? Have you understood? So it's not red, it's not swollen. Those signs of inflammation that you learn in pathology, so they're not there by the time you're cutting into that particular organ. But for contaminated, there's obvious inflammation. It's red, it's swollen, it just looks bad.
So the state of the wound has no inflammation.
Yes. No, the area, the organ that you're going to create the wound, okay. Because these are now surgical wounds, the wounds that you create.
So thank you.
Okay, good. So this is another important thing. Another high yield point is the stages of wound infection. I don't know whether anyone has heard of this before. Has anyone heard? I won't choose anyone for this one. Okay, so when you're talking about dirty wounds, and even clean wounds, there's a continuum that can happen where you end up having a very clean wound, but it ends up causing infection. So there's contamination, colonization, local infection, spreading infection, and systemic infection. So when you're thinking about all of them, the point you're worried is why it goes from just contamination and colonization to now becoming an infection, which means now you as the medical officer in turn or the MO have to actually intervene. When it's contaminated, what you have, and I would highly advise you that you check them out, because these are things you'll see when you're on call. Contamination basically means that there's presence of microorganisms, but they don't multiply. And again, you as the host or the patient doesn't have any response to that contamination. So this could happen whereby a patient comes from a road traffic accident, there's chafu in the wound, but there's no swelling, there's no inflammation happening. So in that case, there's microorganisms there, but they've not begun to multiply. Colonization is usually now the organisms have begun to multiply. So contamination and colonization is very difficult for you to tell because there are no wound signs. And in these stages, you don't, most of the time you just flush and clean the area just to remove, but you might not even be able to tell that this is happening. Local infection is whereby now you've shifted from being colonized, and this at this point they usually say there's around 105, if that's the right number, but you can always confirm. There's in the bioburden, the level is around 105 bacteria per gram of tissue, and at this particular point, when it gets to 106, you're officially now in infection mode. So you have a local infection. So they've now begun to multiply. They're already multiplying, and they're now invading your body and they're interfering with wound healing. Okay. And then we go to the spreading infection. In this one now, they're going into deeper tissues. Yeah. In a local infection, is just at the area. Spreading, they're going deeper. So they're going to your muscles, the fascia, they're going into the intra-abdominal organs and all that stuff. So this one now we start talking about cellulitis, lymphangitis. I think we might have a session in those cutaneous infections, but like at that particular point now we're talking about spreading infections. Systemic infections now, this thing, it's now in the blood. So it's moving within the vascular system, it's moving within the lymphatic system, and the patient at this point have a septic shock, they have severe sepsis, and there's a high chance of death. This rarely happens, but it could happen. But there's usually a very high chance when a patient comes, and I've seen this, especially in internship, in low income setups. Patients usually have like a wound, they were hit by something, and now they had like a small wound and they didn't think it a big deal. Later on, they come with, erythema, the place is warm, it's swollen, and they're in a lot of pain. Okay. The wound has not healed, and they tell you maybe it's been, what do you call this? It's been more than 4 weeks. Okay. That's usually the threshold. After 4 weeks, it becomes a chronic wound. After that, before that, it's just an acute wound. At this particular point, it's become a spreading infection. And now we're talking about cellulitis. And if they've stayed at home for long without cellulitis, then there's a high chance now they progress to systemic infection and they pass on. But it's very rare. But it happens especially if you do an internship in low income areas, you might see that a lot. A lot of people will think it's just a small infection, you don't need to do much, but it has progressed. Yeah. So that's basically it. It's good to go look at this because when we're talking about the risks of infection for those wounds, this particular numbers now determine the continuum and they determine how you manage your patients. So when it gets to infection, local infection, you put topical antibiotics. When it's a spreading infection, now you'll have to put them on systemic antibiotics, either through the vein or oral. And that I think we can discuss when we talk about other things, yeah? So I hope you guys have your smartphones. I would like you to answer this question. Have you guys been able to access that?
Mi niko na mulika mwizi.
So that I can know whether you guys are listening. You just go to menti.com and put that code and then answer the question. So the patient presents with a road traffic accident with severe abdominal pain in the right upper quadrant and is hemodynamically unstable. The consultant wants to go in for an XLAP. What type of wound is this? So let me put more context to this. There's a patient who came with this kind of situation and what do you call this? When they were hit, it was blunt abdominal trauma. They ended up having liver and splenic injury. So then the consultant had to do thumb hepatectomy.
I have a clarification. Is SAP severe abdominal pain? Dr. Gishuru?
Yeah.
Yes, severe abdominal pain.
So, thanks.
We're stuck at 32 responses. Just a few more guys, and then we can finish up. I don't know whether we'll be able to finish by 6. The 20 guys, 25 guys left. Should I close the poll?
Yes, I think we can go ahead. That's okay.
Okay, so which one did you choose? Did you choose class 1, 2, 3, or 4?
Class 1.
So why did you choose class 1?
I think because it's an X lab. So yeah, for that reason.
Okay. What if during the X lab there was some bowel resection? Because it was an emergency.
Yeah, then it would probably be converted to contaminated.
Okay. But I'd explained that in this case that the patient had it was the liver which was damaged, so they ended up doing finger hepatectomy. So we didn't have any bowel resection. Okay. Anyone who put class 2, so that we can know why you picked class 2. No one picked class 2? The 18% of guys? Okay, so the answer to this question is class 1. So at least 75% of you got that right. And it's because we didn't have any bowel resection in this case. So we didn't touch any bowel. So the patient ended up just getting the part of the liver removed, and that's had nothing to do with the bowel. So it's a class 1. So it was a clean wound. So yeah. So back to our discussion. So what is wound healing? There's someone who was talking about wound healing. I don't know who it was. I've forgotten. But wound healing is a process. It's not just a one-day event, and it involves 4 linear process from hemostasis, inflammation, proliferation, and then remodeling. I don't know whether Frederick, what do you understand by hemostasis?
Okay, well, what I understand by it is that there is a cascade of steps that lead to blood clotting.
Okay. So yeah, so based on what you're saying, it's true. So we have platelets, and if you go back to your hematology, I think that was 4th year, 5th year. I think it is 4th year. Not so sure. The platelets are very important at releasing cytokines. So now they lead to the next step. So the first step, we're having vasoconstriction. We're having a plug being formed by the platelets. You can always revert back to your notes for hematology. And then the last part is that they release cytokines, and then you have inflammation. So now inflammation, maybe we can have someone else tell us what I'm just seeing the same names. Gamba appeal. What do you understand by inflammation?
I've lost my voice, but I'll try. It's when your body, it's a process by which your body is trying to fight things like infections or injuries and toxins in an attempt to heal itself. So you have recruitment of the cells, and yeah.
So in this case, when you have a wound, which cells appear first? Is it neutrophils or monocytes?
I would say neutrophils first.
Okay, so you're saying that the reason they're there is to prevent what? Infection, or what exactly are they doing?
It's to prevent infection and promote healing.
Okay, sawa. So now even them, they're also releasing chemoattractants, vasodilators. So they're bringing all the building blocks now to begin the proliferative phase. And the proliferative phase is the growing phase now where we're starting to actually heal the wound. I don't know whether Ireri wants to talk more about the proliferatives. Victor Ireri.
Hello.
Mm-hmm.
I don't know whether I'm in a position to talk because I'm traveling back to school.
Okay, sorry. Karanja Wesley.
Yes.
Yes. What do you think the proliferative phase is?
From what I remember, it's the point where the wound itself contracts and there's a formation of angiogenesis. Yeah, there's also angiogenesis, and I think new epithelium is also formed.
Yes. Exactly. So it's those three things. We have formation of new vessels. We have secretion of extracellular matrix. So this is collagen type 3. Contraction of the wound by myofibroblasts. And then we have the reepithelialization. So those are the things that now form the granulation tissue. These are things that now you'll be asked in the ward. Unfortunately, we can't do it here, but people will ask you, is this healthy tissue or this is not healthy granulation tissue? And then now we get to the later phases of this thing, which is now remodeling. I don't know whether Karaoke can tell us more about remodeling. I think that it's just one or two steps only. Karaoke. Maybe you can ask Kasim Osman. There's also Kasam. I'm seeing there's also Kasam here. Baga. I don't know whether that's how you say it. Kasam?
Yeah, that's how you say it. So we have basically laying down collagen deposition, and then we convert this conversion of type 3 to type 1, which then confers the tensile strength.
Okay. So that's basically it when you're talking about the stages. They might ask you to write up a short SAQ. So just make sure you have those points in your head. For hemostasis, I think there are those two we've mentioned. There's inflammation, proliferation, and then there's remodeling, which is just that one step. So how do they heal? How do those wounds heal? There are those three major ways. You have primary, secondary, and tertiary intention. I think one person can just talk about them. I don't know who I choose. Maybe we talk Victor Otieno. I hope he's with us. He tells us what those three are. Dixon Mwangi.
I'm not sure about that.
Okay. Rebecca Ndongo.
Hello?
Hello, yes.
Okay. I can try.
Okay.
So the healing by primary intention happens when the edges of the wound are like opposed to each other. So it's like it leaves a very minimal scar.
Okay.
Then by secondary intention, it happens when the wound is left open and the edges are far apart. So there's a lot of granulation tissue, and then the scar is a bit more visible.
Mm-hmm.
Then healing by tertiary intention is where the wound usually is left open initially because of things like when the conditions for healing are not favorable, like those factors that influence wound healing aren't present or favorable. Then afterwards, the two edges are opposed, and then now they heal. But
Great.
now, yeah, okay.
Yeah, you've done a very good job, actually. You guys are very intelligent. Primary intention, yes, is when the wounds are very proximal. So most of the time, this is when you have a clean wound or when you've gone to theater. You will close it with a suture. You can close with a suture. You can put staples. You can even put a surgical glue. I don't think you'll find any surgical glue, not unless you do an internship in Aga Khan. But the other places you'll see sutures and staples. Secondary intention, as you say, the edges are irregular and they're not proximal. So in this case, it's a very huge defect. So most of the time you'll tend to leave it and it will close by itself. For tertiary intention, it's sometimes also called delayed primary closure. In this case, there's some form of, as you've said, there's something impairing wound healing. So either it's contamination, poor circulation, or just allow for some drainage. And this we're going to see in the next couple of slides, I think. So you prepare the wound. So with antibiotics, debridement, and then you close the wound. So in this type of wounds is now, if you decide to be a surgeon, these are the places now you'll be needed. So you can either close with wounds, but now you can either close with grafts and flaps. I don't know does anyone know what the reconstruction ladder is? Has anyone come across it? Okay, so that is an assignment for you guys. Go check out what the reconstruction ladder is. So it's very important for you to understand how we go from primary wound closure all the way to a flap, because we're going to be discussing flaps, I think, in a few throughout the sessions. So you need to know the reconstruction ladder, and that is very important for us to start from here. So it's good that I've forgotten her name already.
Rebecca.
Is it Rebecca really? It was Rebecca?
Yes.
Okay, yes. Yeah. Rebecca really took us to the next point, is how do we go from an acute to a chronic wound? And it's basically those factors. I don't know.
1 minute.
Yes.
In what circumstance will we have secondary intention and tertiary intention?
Exactly.
So a tertiary wound closure is, as she said very well, you have contamination, you have the wound has now gone from being an acute wound to becoming a chronic wound because of all those factors which you're going to discuss right now. So what you want to do is prepare the wound either by debridement, giving antibiotics, making sure the wound is now healthy and clean and ready for closure. So now you can either put a flap over it or you can put a graft over it. I don't know whether you guys know the difference. Salim?
Well, not really.
Okay. We'll discuss this later on, but a graft is basically, let's say, for example, you take a piece of skin close to the wound or far. Most of the time they take it from the thigh and they just cover it. So there's partial and full thickness grafts, mostly coming from skin. So you just cover the wound area. And then a flap, you take the tissue itself with its blood supply and you move it to where the hole is or where the gap is. So that's what it is most of the time. So when you have like a huge defect, let's say for example, you have you've been done for a mastectomy and your breast has been removed. So you have a huge defect, and let's say you have loose skin and all that. So you might put a flap. So you move muscle tissue, you move fat and all that to that area from another area. Okay, and this tissue has its own blood supply, so that's a flap, and that happens in tertiary intention. So secondary intention is when the wound is so huge, and this happens most of the time, and you'll see it a lot when we go for your internship, is whereby you cannot approximate the wound edges. Okay, and at the same time, it doesn't make sense to put a flap because now you'll cause even another huger defect. So you allow the wound to heal over time, and then it will close with time. So it's a very huge defect. It's not like a small cut that you just approximate. I hope you've understood now.
Yes, thank you.
Okay, so do you mind telling us some of these factors that impair wound healing? They now push you from one end of the cliff to the other one where you now have chronic wounds. Maybe you can start with local causes.
Me.
Yes, you.
So I think foreign bodies is local.
Yes.
Foreign bodies like bacteria. What
Mhm.
else? If you have poor blood supply,
Yes.
yeah, like where the wound is, the site of the wound.
Mhm.
Yeah, that's local. And then systemic, malnutrition, you use steroids, yeah, chronic conditions, medical conditions kama diabetics, those things.
Okay, so that's good. It's good that you guys know that. You'll see this when you'll see it for yourself when these things happen. So, like, how does infection cause impaired wound healing? There's a guy called Clarence Ruga Otieno. Clarence. Or Yusuf Yusuf Uba Mohammed.
I think the cells will be used more of.
Mhm.
You asked what again?
I'm asking, how does infection prevent wound healing?
Oh, your cells will be fighting with the infection rather than being used for healing.
Okay. So yes, what you're saying is, but a refined way of saying it is that now you prolong the inflammation state because now your body has different priorities. It's trying to get rid of the infection, and at the same time, it's trying to heal the wound. So it will prolong the whole process. So it has two priorities. At the same time, when you have necrotic tissues are written there, it serves as a medium for bacteria. So the bacteria continue growing. So it's like a vicious cycle. So we also had Salim say that there's impaired blood supply. So these are also local factors. So there are these three factors, which well, now we've talked about infection, and now we talked about insufficient blood supply or ischemia. So you break it down into three things, which is pressure, arterial insufficiency, and venous insufficiency. So whenever you describe this even to a lecturer, they know that you know your concepts when you break it down for them like that. I don't know whether Nitin is she with us? Oh, sorry, I don't know. These names are very foreign to me, by the way. Or Patel Ravji.
Yes.
Yes. Do you know what a pressure saw is?
Yeah.
Mhm.
Okay. These are wounds that occur in areas of high pressure, of high
Okay.
pressure, such as the heel, the buttocks. I mean, around the ischial spine. Yeah, in patients who are bedridden.
Sorry, you keep breaking up. You're saying that they are caused by high pressure.
They occur in
Mhm.
regions where at points of high pressure or where most of the body weight is transferred
Mhm.
in patients who are bedridden.
Okay, so how do you think pressure causes impaired blood flow?
I'm not too sure about that.
Sorry?
I'm not too sure about that.
Okay, just think of it as a pipe. If you put pressure on a pipe, it end up collapsing. Yeah, basically
Yeah.
you're basically cutting off oxygen and nutrients to that particular tissue. And I think this the MCQs. I'd ask someone to get MCQs so that we answer, but there's an MCQ that asks about this. You need to know the susceptibility. So is skin more susceptible to pressure sores, or is it the muscles? I don't know whether, Patel, what do you think? Muscles are more susceptible to pressure injury, or is it the skin?
I think it will be the skin.
Sorry?
I think it will be the skin. Because skin is easily devitalized because it's not able to form collaterals as opposed to muscle, which has multiple perforators.
Okay. Yes. So you need more pressure. You need more pressure in the pipe to close down arteries in the muscles, and also they're deeper. Okay. And at the same time, part of the skin is avascular. So if you remove the part which receives some blood supply, then there's a higher chance of it getting damaged faster. I don't know whether there's also arterial injury. I'm seeing there's Josephine here. How do you think arterial injury or arterial insufficiency causes impaired wound healing?
I think it's in line with what you had said about provision of nutrients and oxygen to the tissue.
Yeah.
So if arterial blood supply is impaired or not sufficient, then the wound won't heal properly.
Yes, it's true. It's basically that. So venous insufficiency is where it's a bit unique. So I don't know whether Mumanyi Naftali is aware of that uniqueness. Mumanyi.
Hello.
Mm-hmm.
I didn't get the question.
I'm asking about what is the difference between venous insufficiency and arterial insufficiency with pressure? How do they cause failure for the wound to heal?
Okay, venous insufficiency. When you have venous insufficiency, unlike arterial, you're going to have congestion. And when you have congestion, it's going to impair blood flow also from the body to yes. So when you have impaired blood flow, I think that's how it's going to impair circulation, impairing on healing.
Okay, not so quite. I don't know whether anyone else wants to try. So I'll take that as a no. Venous insufficiency is unique. When the hydrostatic pressure increases, what we have is there's leakage of fibrogen. There's leakage of fibrogen from the vessel to the outer part of the vessel, which now forms a cuff. Okay, it forms a fibrogen cuff. So it's like forming a clot outside of the vessel. Okay. And this now is what interferes with oxygen delivery. At the same time, you also have microthrombi forming because of this whole situation, causing ischemia and poor nutrient delivery. So at the end of the day, when we're talking about insufficient local blood supply, we have to talk about hypoxia and poor nutrient delivery for all of them. How they do it is different. So for pressure, you close down the pipe. For arterial, you have multiple diseases. So that could be vasculitis, scleroderma, atherosclerosis, all those. For venous insufficiency, it's more forming the fibrous calf around the vessel, which now interferes with that delivery of nutrients and oxygen. Okay. So now at least if anyone asks you how do you form a pressure sore, an arterial ulcer, or a venous ulcer, you know. At the end of the day, you also have to know how to classify. I've not put any slides on classifications. I feel that one you can always check up on yourself. How do you classify this type of ulcers? Radiation. Rashid, Fatma, how does radiation cause poor wound healing?
I'm sorry, Doc. I don't know.
Okay. Radiation basically just breaks down the DNA. You need DNA to repair. When you have those breakages, then your cell is not able to have the building blocks and all those things. So you have now continued cellular damage. Okay. There's an element of thrombosis. You can always check that out for yourself. But that also now goes back to what I was talking about before. When you have a clot around the vessel or anything within the vessel, it interferes with delivery of oxygen and wound healing. So now we're done with local. So I remember Salim talked about medication, malnutrition, aging. Well, she didn't talk about aging, but she talked about diabetes. I think diabetes is a whole topic. I think we can even sit here and discuss diabetic for a while. That is something you need to understand very well. Patients with diabetics will become your major problem, especially when you go to the Mashinani, those hospitals. They come with a lot of chronic wounds. And the major reason is because they have impaired wound healing, because all the steps of wound healing, inflammation, hemostasis, inflammation, proliferation, and remodeling are all affected. Okay, so make sure you understand why each one of them is affected. Because this is something that you can actually have a very long discussion, especially if it's in your orals. For aging, aging does not cause impaired wound healing, by the way. That's why I've put a star there. It just causes delayed wound healing. So the older you get, the longer it takes for your wounds to heal. Okay, but it does not mean that necessarily you get impaired wound healing. Malnutrition as well. Either excesses. When you're malnourished, you don't have the nutrients, and nutrients is very important. You don't have the nutrients to heal the wound. When you're overnourished, is that the right word? I can't remember, but when you're obese, there's a higher chance of you getting diabetes. It interferes with your inflammatory process of wound healing, and there's a higher chance of you having chronic wounds if you're malnourished. So for medications, I know you understand the mechanisms of chemotherapeutic agents. You guys are also doing therapeutics, and you know how some of these agents work. They interfere with DNA and all that. And you say radiation affects DNA and wound healing. Glucocorticoids also affect wound healing, and that is if it's systemic. There's some people who you might see putting corticosteroid creams on wounds, and you'll actually see this a lot. There are people who will want you to put a corticosteroid, a cream on top of a wound. I don't know. Does anyone know how corticosteroids impair wound healing? Let me ask Alice Mungare. Alistair. If that's the way you say your name. Mungare.
Yes.
Okay. That's how you say your name, first of all?
Yes, Mungare.
Okay, so how do you think corticosteroids, glucocorticoids, affect wound healing?
I think they affect some of the growth factors.
Mm-hmm. Okay. Corticosteroids have a similar effect to the chemotherapeutic agents. So they cause neutropenia. They also cause anemia, and they also cause thrombocytopenia, which we've seen all those cells, all the cells in the blood are important in wound healing. Okay, so it causes them to go down. That's one. Two, it has a global anti-inflammatory effect. So it affects stage two, the second phase of wound healing. At the same time, it also impairs collagen maturation, which is important for remodeling. Okay. Another one is ibuprofen, which is an NSAID. When I put NSAID there, I was not talking about all the NSAIDs, not aspirin and all those things. The one I was talking about mostly is ibuprofen. Ibuprofen has been shown to interfere with the proliferative phase of wound healing. So that phase of epithelialization and new vessels formation, it interferes with that. How exactly it does that, it's not clearly known. But when you're out there and you're now having a patient with a lot of pain with a wound, then it's better to give them paracetamol than give them ibuprofen or any other NSAID, because we don't know about the others. It's better for you to give paracetamol or tramadol, and you'll see this when you start doing your CSs. You'll there's a high chance that your hospital will not be giving this, and if they're doing that, then these are conversations you can have. But most of the time, after CSs and all that, they don't tend to give that one. The next one is wound management. So that's the other topic. So it was supposed to be one topic, but Cindy told me we do this too. It's a heavy topic as well. I don't know whether you guys need like 5 minutes before I continue, or what do you think?
So just before you continue, sorry, Doc, I'm struggling with the concept of delayed wound management versus, what is that? The one that had to do with age.
Sorry, age. Oh, age. Wow. So when we say delayed wound healing, it means it'll just take longer. If you're older.
Yeah, sorry, it was delayed versus impaired.
Yes, so impaired, it means that we have disrupted the process of those 4 phases. There's a point where we've stopped it. Okay. In delayed, it's happening, but it's happening at a slower pace. That's basically it. So when you compound an aged person with these other factors, which unfortunately they might have, because they have the delayed wound healing, and then you compound diabetes, or they're malnourished, or you're giving them chemo because they have cancer, or you're giving them steroids, maybe they have chronic lung disease, then that affects the wound healing because they're already in a compromised situation, but that's not a risk factor. Okay. I hope it makes sense.
Thank you.
Yeah. So should we continue, or the other thing is complications of wound healing? I think those ones you can go and check out. There are several. There is keloids. There is hypertrophic wounds. I hope you guys have been taught that in class.
Yes, we were taught in pathology. There was just a request from the class. Do you mind if we continue another day for the second topic?
It was actually supposed to be one topic, so I don't know. I was given both the topics to do.
Yeah, I think we can arrange with you for another day. Cindy will be in touch.
Okay, so I think then we need to progress to. I think you guys only have now 3 more weeks in your rotation.
4 weeks.
4 more weeks.
Yeah.
Including this one, so we can only do 3 other topics. So I had asked the class reps to choose high yield topics. I don't know which ones. I don't know whether you guys are shown the list of the topics that we are supposed to do. that you should at least know before you do your exam?
No.
Or you guys are not sure? Maybe Cindy, you can show them and then they choose the other topics so that we don't dwell on wounds too much, and then we don't talk about flaps and grafts and the other topics which might be important that might affect your exams. Okay, sawa sawa basi. Aya guys, any other question? Okay, so what I will do is I'll send Cindy a Google form for you guys to fill, just to note who attended and any issues you guys might have, so that I can address. Yes, I think that's basically it.
Thank you for the lecture.
Tutorial.
Yes, tutorial. Thank you.